Go.
Welcome back to another episode of the Sports Medicine Project. We have a return guest, our first return guest. Maybe not. Justin might be a return guest.
No, first proper guest. First return guest.
Justin's not a proper guest.
Yeah.
We have Dr. Stephen Kent with us, part 2 on syndesmosis injuries. So we talked about syndesmosis injuries briefly in the last episode, and we were keen to really pick Steve's brain. So welcome.
Oh, thank you. Thanks so much for having me back. I'm glad I'm seen as a proper guest, and I'll let Justin know that he's not not a proper member. No, really glad to be back. I was really keen to be back. I wondered how the last one went, so it must have gone okay, I guess, to be back.
Yes, yeah, it did really well. Yeah. And a lot of the case studies as well, it was good. I think we got more feedback from our younger clinicians, which was good, because like we said in the first one, people just don't get that opportunity to hear from an orthopaedic specialist, and hear what your week looked like, how you treat patients, what surgery involves, that kind of thing, which was awesome.
Yeah, great. Yeah, no, look, I think what I've actually realized in listening to you guys is there's a big disconnect between, say, where the surgeons are or specialists are, and then, say, sports docs, and then podiatrists, allied health, physios. It's quite like I was listening to your podcast with Justin the other day about sort of imaging, right? And we see a lot of the imaging that comes to us ultimately, and it's not ordered by podiatrists, I'm not saying, but in general, a lot of the imaging actually we then reorder. Right.
Yeah.
So I was talking about my colleagues the other day, there's a lot of wasted money in terms of imaging. And so it's not wrong to order imaging by any means, but it just showed me there was probably a spot, all the stuff you guys talked about was great, but there's a real deficit in terms of us trying to get messages out to everyone else around in terms of educating and talking about that sort of stuff so we're all on the same page, because there really is a real disconnect between each sort of level of care, which is getting better and better, and podcasts like yours are making that much, much, much easier. But probably it should be an onus on us surgeons or specialists to be out here doing this sort of stuff, I think, because it really helps, and ultimately it's better for patients, right? So and that's what the great thing about your podcast is you've got a whole different range of guests. So I love listening to, I was going to say I listen to a lot of them. So and I learned a lot from Nikki's one the other week too. So
that was a good one.
That was good. Yeah, I really appreciate that. It's great. And like we were saying with the imaging, I mean, you don't know what you don't know. You can think this is the best imaging modality for this, but I mean, you don't know really.
No, look, trust me, we get it wrong too. And the lucky thing we've got is that often we get a Medicare rebate for our imaging. Okay, so there's less pressure for us not to do it. As in, we just write a form and it'll get done. And so we've got to be really mindful too. We're sort of the gatekeepers in terms of that, in terms of the cost to the whole healthcare system. And so you really do, if you're going to order a test, and you guys made a good point, MRI, so you could MRI everybody, and you would find about 5 different things that would be reported on the image that actually don't matter. But if the patient listens to that or reads it, or it's interpreted by the wrong person, that can cause real damage in terms of their beliefs and ongoing care, et cetera, et cetera. So, I mean, classic one of those things like discs in back pain and things like that. Yeah. So I think talk about that sort of stuff is fantastic. And as long as we're all on the same page, then that's fine. So, and I think more we sort of engage together is helpful.
Just the better. Now, for our new listeners, so whereabouts do you work? What kind of work do you do? What's been your story, and how did you end up, practicing where you are now?
Yeah, so we went into a little bit last time. So I'm based in Newcastle, New South Wales, Australia. I operate predominantly in the private hospitals, Lake Macquarie, Private Moynes Bay. I'm a foot and ankle orthopaedic surgeon. So that means I'm trained in all aspects of orthopaedics, but I've gone down sort of a subspecialist foot and ankle pathway. And my interest is particularly foot and ankle sports injuries, one of which is syndesmosis that we're talking about today. And then in terms of back in my training, I trained predominantly in Newcastle for my orthopaedic training. And then went over to Brisbane to do some what's called a foot and ankle fellowship. So look at a lot of sports-based foot and ankle work up there with a lot of professional sports teams and some very excellent foot and ankle surgeons up there. And then went over to Toronto in Canada in what was supposed to be 6 months, but had to leave about halfway through for another fellowship over there. Left halfway through because of COVID, essentially, and then started up practice here in Newcastle in the middle of 2020, or early 2020. When no elective surgery was going on. So that was a great start. Yeah, so, and I do on-call at the local private hospital, Lake Macquarie Private. So I do a lot of fractures all over the body, not just the foot and ankle, but my predominant elective work. So people that come through my door to see me in my office is foot and ankle based work.
Yeah, very nice. And yeah, today's topic is in syndesmotic injuries. I'm really intrigued. I know Kelly's going to be the driver of this conversation. I mean, in podiatry, we typically don't see those acute, I guess, ankle sprains. They present to physio a lot more than podiatry. So I'm really interested to see, and really, I mean, I don't know much about them at all, just because I don't see them that much, only what I've read. So I'm really interested to hear, you know, what you two are going to talk about, and me just kind of sit in the back seat and learn a lot, which will be good.
Yeah, I'm really interested as well, because I've probably over the more recent months and probably a lot of it since seeing a lot of your patients, Steve, but I've always thought that syndesmosis injuries were just like a membrane, like the tear or an injury to the membrane between the tibia and fibula. And I now understand that that's a bit of, well, syndesmosis injuries are a bit more of an umbrella term, and there's lots of different things that can fall under that. So I'm really keen to hear about some of those more common presentations, or maybe not so common presentations, and a little bit of the anatomy around the syndesmosis.
Yeah, excellent. Yeah, it's a very little known topic, really. I'd say even orthopaedic surgeons, there's a percentage of syndesmosis injuries we actually don't get taught about, funnily enough. We all know the anatomy, but my colleagues, when they're training, the registrars coming through, they will not see many of what we call soft tissue syndesmosis injuries, meaning that what's done in the NRL on a weekend basis, they wouldn't have seen, possibly not seen one, or they would have seen them in ED and thought they were a typical ankle sprain. So it's not a well-known injury outside of really a foot and ankle domain, funnily enough, and physio domain, really.
Yeah. So what's the specifics? Like, what is the syndesmosis? What is that whole area, and what does it involve?
Yeah. So syndesmosis is an area at the ankle, essentially, right? So it's the join between the tibia and the fibula down at the ankle. And so that's and basically the tibia has got a bite out of it, a groove, which the fibula sits in. And then it's held in that groove by 3 ligaments, one at the front, holding the 2 together, one at the back holding the 2 together, and then one actually between the bones that holds them together. And then obviously as you go further up above the ankle, there's a membrane called the interosseous membrane, which holds the fibula and tibia together all the way up to the level of your knee. And then there's another joint of ligaments up near the knee where meets the fibula. Now that's not syndesmosis all the way at the top, but essentially the syndesmosis complex extends all the way from the interosseous membrane down to the ankle where those other 3 ligaments are. And it's an incredibly important part of your body, essentially. So if you rupture maybe one of those 3 ligaments, you might be okay in terms of long-term effects to your ankle. But if you injure any more than that, there's reasonable biomechanical evidence that would suggest that you may have long-term issues with your ankle as a result. Okay. And so the reason we call it it's known as a high ankle sprain, is because it's an injury to ligaments at the ankle, but it's at a higher level than we typically see in an ankle sprain. So the ligaments that we're commonly looking at in a typical ankle sprain, where you roll your ankle, say playing soccer or football, or you roll it down a gutter, typically they're further down where the fibula actually attaches to another bone in your ankle called the talus. And they're really common, as we talked about in one of your other podcasts. But the high ankle sprain probably makes up about 1 in 4 injuries in contact sports. So it's not actually that uncommon. And there was a study done recently in European soccer that said about 75% of those injuries are made up in a collision or a tackle. Okay, so typically they're going to be in positions where you're playing sport or doing something where you come into contact with something rather than just twist the ankle, although it can happen with just a simple twist. And the mechanism is different, which we can go into. But essentially, you've got a ligament at the front called the AITFL, or for a long name, anterior inferior tibiofibular ligament. No one's going to remember this, but basically the front one is known as the AITFL. The back one is called the PITFL because the back is posterior, that's the P, and the one in the middle is called the interosseous ligament. And so the single most important one of the whole lot is the posterior one. It's the strongest. It's the hardest one to basically get rid of or break. The other 2 usually have to go to get to that. Just a quick tip for anyone that's gets an image of the ankle. So that can be an ultrasound or an MRI, and they're reading the report and they just see all this garbage in the report and lots of names, look at medical jargon. If they talk about a ligament and it's got an I in it, and what I mean by that is if they talk about AITFL, because just to confuse things, the typical ligament you'll injure further down in a typical ankle sprain is called the ATFL, okay? If the ligament's got an I in it, then that's the syndesmosis, and you should be more worried, okay? Or if they call it the anterior inferior, so hardly ever they put that inferior in after an anterior with a ligament other than the syndesmosis, okay? So if it's an anterior inferior, tibiofibular, so any tibiofibular ligaments, so ligaments between the tibia and the fibula are ones to worry about. That's the syndesmosis. Right. When they talk about talo, so the talus, and then go from the talus to the fibula, that's further down, and that's typically a low ankle sprain. So it's really confusing, right? Like really confusing. But basically, if there's any abbreviation in there with an I in it, be worried about a syndesmosis. Or if they talk about anything between the tibia and the fibula as a ligament, be worried about it based on imaging. Okay, and maybe you need to have a chat with someone like a sports physician or a surgeon about whether that's an injury that might need to be treated with surgery, possibly. So that's a lot.
You mentioned biomechanical changes if these aren't managed. What are they?
Yeah, so there's been studies where they've taken cadavers and then, so they've put them in a basically they've held them constrained, they've cut the ligaments from front to back, and then they've applied an axial force, and then differently they've then applied an axial force with external rotation. So I see patients that have had what I see on MRI as a really bad syndesmosis injury, which I would have thought they'd be limping in, hardly walking. They're 3 or 4 weeks down the track, and they say to me, "It's really good." Like, really, is it that bad? Like, why am I walking around here with no pain? The biomechanical changes actually show that if you go through, say, just the AITFL, the center of pressure through your ankle actually probably doesn't change all that much. So mechanically it changes a little bit, but not hugely. And so we think that probably doesn't make a massive clinical difference. Once you go through the interosseous ligament as well, or you go through the interosseous ligament plus the PITFL, the one at the back. So if you have more than one ligament injury, if you've got 2 or 3, then what you see is that the center of pressure that runs through the ankle in a lab actually starts to move posterior laterally. So it goes from being in the middle, and it can move up to 6 millimeters posteriorly. So it moves a lot. So that's in a lab condition. So that's not a real person, and that happens that only happens with external rotation as well. So that's why I think I see patients that are actually pretty good when they walk through my rooms, yet their MRI looks pretty terrible. So because just an axial load, the actual congruence of the ankle is maintained, even if you've gone through all 3 syndesmosis ligaments. And so what you're basically worried about is if you ruptured all 3, that fibula can move around. That's the worry, and that means the joint's loading abnormally. So what we know is if we cut 2 of them, we already start to see the center of pressure move, and when we cut 3, it moves further. So what we think from that is your cartilage that's made in your talus bone and in your tibia is at different thicknesses at different areas, okay? And so it's made that way because that's how, when everything's intact, that's how it's loaded, okay? But if you change where most of the pressure is going through in the talus, and all of a sudden you start to load an area that's not quite as thick, for instance, you would worry. And there's not a study that says we looked at everyone that had a syndesmosis injury and we saw how many had arthritis 20 years down the track. There is not a study on that. So I can't say on this podcast, you have a syndesmosis injury and it's not treated, you'll get arthritis. I can't say that. Absolutely. Or you'll get emails that say, well, he's lying, or there's no evidence to prove that. Right? But I would worry. If it was my ankle, I would worry that if I've gone through more than 2 ligaments, I want to know if my fibula is stable. That's for me, right? And I would worry for that for my family as well. That I know from that biomechanical data that it's worrying, that the center of pressure does change. And so anytime that if I'm a rugby league player, for instance, I'm going to have a lot of external rotation forces when I'm being tackled, when I'm pivoting, that sort of stuff. And if that's happening to my ankle over a long time, if it was left alone, is that going to mean, I would worry then that potentially extrapolates to you getting a long-term issue like arthritis or something like that. But more importantly, what we know from syndesmosis injuries, they're not treated, they're a higher risk of having what's termed as long-term ankle dysfunction, which essentially means ankle doesn't feel right, either feels unstable or painful, or is impacting their life, basically.
So is that the risk why, like, compared to ACLs and Achilles and things, non-operative versus operative, is that why it's such a high risk injury earlier on?
Well, it's actually quite a controversial injury. It really is. You can pick another surgeon on this podcast and you probably get a different opinion, if I'm being honest with you, right? So there are groups of surgeons like myself who worry about it a lot and are reasonably aggressive with them, okay? And then there are other groups of surgeons that feel they should be treated similarly to low ankle sprains, and they should be allowed to sort of let run, see how they feel symptomatically. And if they then develop ongoing symptoms, basically, then maybe they should be treated. So there's different, and the reason for that is there's a paucity of evidence in terms of long-term problems. So because no one's really studied it. So there are studies that show that if you compare low ankle sprains to high ankle sprains, they're more likely, say, to maybe have long-term pain or issues getting back to sport or something like that. But we don't have any long-term data that says they get arthritis. We don't really know, to be honest. And so that's why you might go to, and I've had patients myself that have gone and seen another surgeon and been treated non-operatively, and they come around to me after not getting better or something. But I've also seen patients that are like 12 weeks down the track that on their MRI, they've had a really bad, they've gone through all 3 ligaments and they're feeling fine. And they say to me, do I really need surgery? And that's a hard conversation, because I say, well, I would worry long-term, but I don't actually have any proof of that. That's just my thinking based on the biomechanical data. And so that's where it actually becomes tricky. And that's why you'll get some differing opinions on that. But you'll see all the sports stars, they all get treated. They all get operations, all of them. Okay. And if I sort of feel like if it's good enough for that, well, I don't treat it just because they get it. I think the biomechanical data makes me worry a lot. And so as a result, I treat them. The other thing is, lastly, I'm going on a bit, but we know for ankle fractures where there's a syndesmosis injury as well, if the syndesmosis is not sitting in the right spot with those fractures, there's evidence proven in studies on that they are more likely to get arthritis, and they are more likely to have some ongoing issues in terms of pain. So we know from a fracture point of view, if we don't put the syndesmosis where it should be, that they get long-term problems. But it hasn't been applied to those ones where the fracture's not involved.
Yeah.
Right.
Interesting. So I wanted to ask, like, I know it's a two-part question. How commonly do you see the missed? And then, depending on that answer, what kind of clinical presentations do you see to then make you more suspicious? Like, this is definitely, needs to see yourself, or sports doctors on needs further imaging.
Yep. So I say, the literature would say they missed in 20%. I see missed. I guess what I can say to you is I rarely get them referred directly from a GP. I typically get them referred, if they come to, and I would think I would see more than others because that's my area of interest, but I typically have them referred through a physio. Physios picked it up more often than not. They're much more aware of the injury, just through the difference in training than the general practitioners. It's just not that well known. I probably see maybe 1 out of maybe 5 or 6 through my practice that's missed, and that falls into that sort of subacute or chronic group, I guess. But the literature would say 1 in every 5 at least is missed. The reason they're missed is they're actually very hard to diagnose. So the reason they're easy to diagnose in the sports stars is because you actually see the mechanism of injury on a video, which we don't. When patients come into you, Kelly, I'm sure most of them can't see which way their ankle went when they did the injury. So the things so typically how you do a syndesmosis injury is it's got to be usually a dorsiflexion and external rotation mechanism, which is the opposite from a typical ankle sprain, which is usually an inversion type injury. Okay, the patient won't always know. And that's half the problem. And the other problem is that you're typically looking for tenderness over the syndesmosis itself, which is over the sort of anterolateral aspect of the ankle where the tibia meets the fibula. That's where you're looking for the tenderness. And then you're also looking for potentially tenderness further up the interosseous membrane. So we know, for instance, that if the tenderness goes, say, more than 5 centimeters above, if someone's playing sport, that actually affects the amount of time they get back. So if you've got an injury to the interosseous membrane, it's much more likely to be a more problematic injury. So the problem though is that you can have tenderness over the syndesmosis in about between 40 and 60% of low ankle sprains. So ankle sprains where there's actually not an injury to the syndesmosis, which is very confusing. So if you just went off the tenderness alone, that doesn't really tell you whether they've got a syndesmosis injury or not. If they're not tender over the syndesmosis, then they're not going to have one. But just if they do, it doesn't necessarily mean that that's the injury.
That's confusing.
So you're looking, which is really confusing. Okay, so basically, number one, you're looking for the injury. If the patient describes an external rotation, so an eversion type of injury, that's pretty likely to be a syndesmosis injury. That should have a high suspicion to begin with. Okay. If they're playing a contact sport, like I said before, the contact sports are more likely. We've recently seen like the hip drop tackle in the NRL. That's typically how they've been done lately in the NRL. So contact sport, that should also prick your ears up, that it's much more, it was in contact, like a tackle playing soccer, tackle playing rugby league, rugby union, much more likely to be a syndesmosis injury. All right. They're the two. You have to examine for tenderness. So if they're tender over the syndesmosis, all we can say is it might be, but it may not. Okay. And then you've got your special tests, which are what's called an external rotation test, which basically means very firmly bringing the patient into external rotation while holding the tibia, and you're looking for pain as a positive sign. And then the other one is something called the syndesmotic squeeze test, which is done about 8 to 10 centimeters above the level of the ankle, and you basically squeeze the tibia and fibula together, and you basically try to provoke pain. Now, the problem with those tests is they're not particularly accurate, as in they're not specific. So they can be, I definitely have seen patients that had very positive tests, didn't have a syndesmosis. Okay. So they're useful. They're sort of giving you some information, but they're not going to say, yep, if you've got this, you've definitely got the injury. They just sort of add to your clinical suspicion. Okay. And so all you can do is sort of really realistically those 4 or 5 things. Okay. That doesn't give you an awful lot of information realistically. The kickers are the external rotation injury, really. That's the big one. And I would place some value in the special tests, but once again, not 100%. If they're not in one of those sort of high risk categories like a rugby league player, soccer, etc., then you probably can actually see where they're at maybe 3 or 4 weeks down the track. Okay, because a lot of our ankle sprains, typical low ankle sprains, are starting to get better with some rehab by that point. And you haven't really missed the boat to treat a syndesmosis injury anyway. If you've got a patient then that's really not getting better and their pain is very much over that anterolateral ankle still, then that would add weight to their possibility of being a syndesmosis injury. Okay, and that might be a time where you might think of either another opinion or some higher level imaging, which particularly with syndesmosis injury is an MRI. If you look in, on the internet or in books, they typically talk about an X-ray looking at spaces around the ankle. Okay, things like tibiofibular clear space and that sort of stuff. That's the traditional teaching. The X-ray will pick up a howler, basically, meaning that if there's a big gap between the tibia and the fibula, or if there's a big gap on the medial side between the medial malleolus and the talus, that they'll pick that up. It'll look really wide and really obvious, and it'll pick those ones up. But as for measuring little distances on an X-ray and trying to work out if it's 2 millimeters more or something to the other side, the accuracy of that's been shown to be really poor. And the reason for that is poor radiographer can't put the feet in exactly the same position every time. Like, that's not going to happen. Like, I can't do that when the patient's asleep and get the same X-ray on both sides all the time. So the radiographer, the patient awake, is not going to be able to do that easily or accurately. The other thing is that it's been shown in studies that you can't reproduce it person to person, as in everyone measures something different. So, and it's also been shown not to correlate with the MRI findings. So you can have a 3 ligament rupture on an MRI and the X-ray will look pretty normal. A weight-bearing X-ray will look normal. The other thing is the fibula usually translates posteriorly in the injury. So we've typically been looking for it to move sideways when actually it moves front to back. And so the X-ray is not great at picking that up either. So I would still recommend X-rays, because if you miss a fracture, then that is really bad. and they will present very, very similarly. So an X-ray is still valuable, definitely as a first-line investigation. But what I'm saying is if the X-ray is normal, or you're trying to pick up different little gaps based on measurements, then you can't rule out a syndesmosis injury on an X-ray.
I'm really glad you said that, because that's something that I've routinely done, is sent for bilateral weight-bearing X-rays to rule out a syndesmosis injury. And it's something that I've always questioned, because I've thought, like, if this is a really bad syndesmosis injury, maybe it will show something. But if it's a minor one, it's probably not going to show anything. So what am I actually doing it for? So I'm really happy that you've said that.
I wouldn't go straight to, I said, like, I think I did this the other part. Like, I don't want to send on a message being go MRI, everyone, you worry about syndesmosis injury. Like, because that's bad. So I just didn't usually get an X-ray first. There's no one, I can see, guys, there's no one I definitely do X-ray, and I definitely want to weight beam X-ray. And there have been 1 or 2 occasions where there's been a fracture picked up. Okay. I know we haven't talked, this is another topic, but it's something for a major nerve injury, which is a fracture associated with the syndesmosis injury. And that can present that way. And so you'd need to do an X-ray. I guess you just can't rule it out. Okay. So definitely people you're worried about syndesmosis injury, please X-ray them, because you don't want to miss a fracture, because they present very similarly, but you just can't rule it out based on an X-ray alone. That's all.
Yeah, it's good. Like, and this is like we were saying, and we were saying at the start, having, the podcast previously with Justin, just talking about imaging, there's so much more complexity to these things, that one, what you're taught, and also what's in the textbook. Like, I know for most people, this is going to be completely new information, and they would assume, weight bearing X-ray, that's what you really need to get. But knowing that there's certain times where it is more beneficial compared to an MRI, and then a combination of them both. So, that's where your specialty, obviously yourself and doctors and things comes into it.
Yeah, and look, there's other things. So if you go look up the literature, like even reading papers, so if you look up the literature, so it's, ultrasound is actually in the literature said to be very accurate for picking up the injury as well. The problem is that but those studies are usually done in sports centers where the sonographer is just looking at ankles all the time, or ankles and knees. So their level of expertise is fantastic, because they're looking at anatomy under an ultrasound all the time. Okay. Australian radiographers, ultrasonographers are excellent.
Yeah, sorry.
They're really, really, really
close
good.
this door.
You're right.
So we'll edit that out.
That's
open
okay.
that door.
They're really good, but they're doing a range of pathology. So they could be looking at pregnancy one day. They could be looking at wrists. They could be looking at hearts. So they're excellent at what they do, but they might only be doing an ultrasound for a syndesmosis once every couple of weeks or something. And so I guess from my point of view, I don't place a lot of value in the ultrasound, because it's what we call user dependent, meaning that I actually can't really read the images when they send them to me later. You actually need to be there at the time to look at it and make an interpretation. And so the difference, I guess, with an MRI for me is I can look at it, look at the image and say, well, yeah, I can see where those ruptures are, and show the patient and know that, I guess you're basing the information on what I can see and my interpretation of it. Whereas a sonographer, it's ultrasound, unfortunately, is very much user dependent. So you can't extrapolate the studies that show it's really good. That means as a tool, it's really good in the right hands.
Yeah.
But you can't generalize it for everything. So each modality, actually, you've got ultrasound, MRI, probably both pretty good, but the ultrasound in particular is going to be very dependent on who's doing it and where you're getting it. So if you're getting it at a place called Aspetar, which is the place that looks after all the FIFA injuries, then there's probably really good. You can place great faith in that, and it'd be much cheaper. So, but we probably can't extrapolate that to here. Yeah.
What would you recommend? And I know it's incredibly hard and complex to answer this question, but if someone is suspicious of a syndesmosis injury, what would be, do you think it's best management, again, depending on the severity, to send to someone like yourself or a sports doctor initially, or for them to order the right imaging, or what do you think? Because obviously I can see the benefit and the con, but what would be your opinion on that?
Oh, it's actually really hard to give good advice on that. My advice, most of the physios I meet, I tend to say, look, if you really worry about syndesmosis injury, just give me a call and I'll get them in. I think if you're worried about it, I think those ones, there is a bit of information to say if you get them within 6 weeks, that they're likely to do better, say that if you get them a bit after that, in terms of for the ones that need to be done surgically. So my take on that is, because there's such an airy-fairy type of diagnosis, realistically. So unless you're pretty confident based on mechanism, what the patient's told you, history and risk factors, I would probably, if you're worried about it at 3, 4, 5 week mark, I would refer it on at that point without, the only imaging I would say is get an X-ray.
Yeah.
That's all I would say at that point. And then let that next person work out based on the referral. Because typically if I get that referral from a GP or a physio or a sports physician, I will order the MRI based on that history before I see the patient more often, if the history is strong for it. So, and that's more actually just from a point of view of trying not to waste imaging money and modalities and that sort of stuff. In a perfect world, for ligamentous and most things, you'd MRI them so you know what's going on straight away.
MRI in the corner of the clinic room every time.
Yeah, but you can't do that for a resource point. The other thing you'd find things you're not trying to, like I had a kid who wanted to go play a futsal tournament overseas or something, and I was positive he had a low ankle sprain, but I just needed to rule out sort of like a growth plate injury or something so we could just rehab him faster. And lo and behold, I found something else I wasn't planning to find on that MRI.
Yeah, that was weird. I know who you're talking about.
Yeah. So there is dangers to over investigating as well. Okay, so I think for those high level tests, unless you're, say you've got some games in first grade in local regions now telecast on YouTube, whatever. Unless you've seen the mechanism, like, oh yeah, he definitely externally rotated there. That's going to be syndesmosis. Okay, I'll order that MRI. That in that situation, yeah, sure. But I'd probably leave it to the next person. If you're a reason, like for me, I get them in fast and I like seeing them and it's my thing, so I have no issue with that. I would imagine most surgeons for that type of injury would be happy to get them in quickly. To me, it's like equivalent of an Achilles or something like that. It's not something that they're going to say, you shouldn't have sent me here you shouldn't have sent that patient on without imaging kind of thing. I think as long as you've got an X-ray, I think that's enough. Yeah.
Yeah, God, I tell you what, those contact sports, I'll be sticking to running. That's why running's the best. There's no one hit me from the side on my ankle.
Well, you never know. If you're down a hill or something like that, slip like wet grounds, someone treads on your leg as you and rolls it outwards. It can happen.
Right. Come on, mate. Give me a little bit
Not
of
likely.
confidence. I'll be strapping my ankles, I'll be casting it, bloody orthopaedics and everything over the top this afternoon. And moving a little bit more to the rehab side, and I know, Kelly, like you've definitely rehabbed way more syndesmosis injuries than myself. I mean, what do you like to see from clinicians post-operatively? And then also when they've seen you for an opinion and you've said, no, I don't think this is a surgical case, go back and see the physio.
Or not even post-operatively, even if it is one that is managed conservatively. Or not conservatively, non-operatively.
Non-operatively, yeah. So typically the ones where we're treating non-operatively, they've sort of got a single ligament injury, so it's got an AITFL injury, or we were worried that a 2 ligament injury, but so the crux that 2 ligament injury is some are unstable and some aren't. So some have excessive movement and some don't. The only way you can tell that is under an arthroscopy. So we have to actually take them to an operating theatre and test it. So there'll be some that actually have an operation, but they don't get any stabilization or fixation. And then we can treat them just like a grade 1, essentially. They're probably going to take a little bit longer to recover, but you can rehab them simply. Typically, the good news is for syndesmosis, whether they're operative or non-operative, is that the rehab's actually pretty good, pretty simple. It's not terribly complicated. You're trying to reduce that amount of sort of external rotation, dorsiflexion movement in that sort of 4 to 6 week period, essentially. But majority of the time, say for a grade 1, I might let them start weight bearing in a boot by say the 2 week mark, and try, if we're really lucky, to get them out of the boot somewhere between the 4 and the 6 week mark. And they can sort of they can definitely start range of motion from the get-go, but they can really start some sort of ankle strengthening and proprioception work from that sort of 4 week onwards. Now, the time they get back is a bit variable depending on the sport and what they do, but typically they will take longer to rehab than a typical ankle sprain. So whilst it sounds like we're pushing them through based on that rehab, they tend to take longer to get back than a low ankle sprain. So funnily enough, I think I'm sure you've seen the post-surgical ones, Kelly, that after surgery, they tend to rehab pretty well. They're pretty quick. That's what I found. Yeah. So
100%.
I don't think there's any papers that say they get back to sport quicker, but I presume they should. based on just what you see from a rehab perspective. Usually you're more confident that it's stabilised, so you're usually happy for the physio to push them
I
harder
also
than
wonder,
you would say
I
a
also
grade
wonder
one.
if,
Yeah.
sorry to interrupt you. If
Yeah.
the group that they tend to happen in are typically more the sporting people rather than people that, I don't know, maybe that has a factor in that as well.
They are, and I've definitely seen non-sporting people take a lot longer, like a lot longer. You're right. They're usually motivated people. They're usually trying to get back to play. They're usually aware of the injury because they've seen their colleagues have it. We're typically talking about rugby league players, I think, and union players. And so they know they can get back to it in a certain time frame based on what they've seen for others. And so they know they can push it after surgery, and they're motivated. So you're right. Yeah, you're absolutely right. The other thing is, though, is that the literature is a bit funny on it. So, like, I know from like following the NRL physio on Instagram, where he puts up how quickly the NRL players get back from their syndesmosis injuries, and it used to be like sort of 12 weeks, and now it's almost down to about 6, which is
that
really
post-operatively?
fast. Like really,
Post-operation?
post-operatively, yeah. But the literature would say something different. So they've looked at professional soccer players and treated by like a world-class organisation that does a lot of syndesmosis injuries. And I think the average time to return to play in the professional soccer players was about 100-something days, something like that, which is a lot longer than what we see in the NRL. Now, it'd be great for me to sit here and say, oh, the surgeons are better, but they're probably not. Physio is probably equivalent at least, and they're probably getting a similar amount. So I just wonder whether it's the expectation that's different. Because I would have thought the rigors of your ankle playing rugby league for that type of injury would be worse than a soccer player. Even though soccer player is running more minutes and probably pivoting a bit more, your average rugby league, rugby union player is getting themselves constantly into positions where their ankles are being rotated, particularly nowadays as opposed to say 15 years ago. There's a lot of wrestle in there. There's like third man in. There's a lot of tackles where they're really twisting. But we don't see a lot of, this is just anecdotally, just from watching the NRL, I don't see a lot of repeat offenders in terms of repeat injuries. There's one or two that spring to mind. Funnily enough, they probably play for Newcastle, but there's not many that I can think of that keep having the injury.
Is that in that absence of a fracture as well, or?
Yeah, they're sort of different beasts, I guess.
Yeah.
They're different. They're much the same, and the mechanism's the same. Fractures will take longer in general. It's usually a bigger operation, more dissection in terms of bigger cut. There's more hardware left in the patient. Usually it's a bigger rotational injury. There might be other, rather than just a syndesmosis, there's a fracture, so another injury. So we don't typically see them come back and do another fracture, but definitely their rehab will be. So the study I was talking about, the soccer players, and then talking also about the NRL players in terms of that 6 weeks, that's just purely soft tissue syndesmosis injury. That's not a fracture. I suspect the fracture will take at that level of play, the best I've got back, that's an NRLW player, was about 10 weeks with an ankle fracture with a syndesmosis. Yeah.
So you think of just like healing time frames, like 6 weeks is very quick just in regards to that. But yeah, I don't know. Oh yeah.
Yeah. No, I agree. I suspect they're relying on their tight rate at the 6 weeks. That's typically most giving the tight rate. That's the fixation. So it's like
I was just about to. My next question was, can you talk much to the surgery? Not in the sense of we want people listening to this to be educating their patients on the surgery, but just so they have an understanding of the different types and maybe when one's more indicated than another.
Yeah, so in terms of indication, in terms of what's put in, it really purely is surgical preference. Okay, so surgeons will argue one way or the other and why they do it and whatever. The literature would say that, so we're talking about basically either putting in a screw or putting in something called a tie rope. And a tie rope, basically both surgeries involve you drilling holes from the fibula, so the outside portion of the fibula, all the way through the fibula, then all the way through the tibia out to the other side of the ankle. And then putting in some sort of device that basically sucks the fibula to the tibia and stops it from moving excessively. Okay, so that can be either a screw or a tight rope. And the tight rope is basically a strong synthetic fiber that sits in the drill hole. And then on either side of the fiber are two metal buttons. They literally do, they look like buttons. And they basically squeeze the two bones together. Okay, now they both work. We know they both work. the advantage of the tightrope is it usually stays in forever, whereas screws can break, and sometimes some surgeons would remove them routinely. Other surgeons say just let them break and leave them in. And there's some evidence to say leaving them in is okay. I've done a mixture of both. Typically, surgeons will evolve over time. So I actually started off putting a lot of screws in. I put more tight ropes in now. In certain big patients, I'll put a screw in first and actually exchange it for a tight rope a certain amount of time later. Because basically the difference between the hold of the two is that the screw actually holds the fibula dead still, essentially, whereas the tight rope allows a bit of micro movement there, which is more physiological. But in some, but basically the literature would say that both of them work. So there's not a right or a wrong answer. So if you've had a patient that's gone and got a screw, that's not wrong, and it'll still work absolutely fine and work very well. And you have a patient that's had a tight rope, then same deal. So, and foot and ankle surgeons have been arguing about that for like 8-10 years, basically. And there's been lots of RCTs and studies, and basically both are right. It's really whatever the surgeon wants to do that works for him, basically, but they'll both work, essentially. Okay. As long as the surgeon has a good reason.
Is there much to like bracing and things like that post-operatively? I mean, like, can you brace or wear any kind of brace around the ankle or around that area of the leg?
In terms of what, treating them non-operatively or preventing the injury?
I mean, that definitely won't be able to prevent. I wish. I mean, only orthotics prevent injury, but that's another topic.
Yeah, of course. Absolutely.
Like even like post-operatively, or if you have managed it not in a non-op situation, is there anything to wearing braces? Like, do you ever recommend that? I mean, is it just more of a proprioception thing, or?
I've recommended them for low ankle sprains, absolutely, because there's good evidence to say they reduce the incidence of low ankle sprains by a considerable margin. I think it's like 75% or something. I don't know the literature on high ankle sprains.
I don't know about high ankle. I tend to. I mean, but based off low ankle sprain, taping for a high ankle sprain, I'd probably just like reinforce the anchor a little bit more up the top is what we kind of tend to do, like squishing the tibia and fibula together a bit more. But
I know from a symptomatic. Sorry, Kelly.
Sorry. And I guess like there's no harm in taping someone up to 6 months after an injury, after a higher ankle sprain, which is what we tend to do for a low ankle sprain. So maybe.
No, true. And I know symptomatically patients, anecdotally, they feel better with taping around the syndesmosis. So I don't think it's not that you're right, Blake. It's not going to prevent an injury. You know, typically they're quite severe injuries if you watch them on the videos. I think definitely as part of your non-operative treatment for, say, a grade 1, then I think taping it is absolutely advisable, and probably for sort of 3 to 6 months, particularly returning to sport or training, because you really are trying to limit that external rotation abduction movement. So the more you can provide that sort of buttressing to the fibula, the better. Although we sort of know from taping that after a period of time, it's less effective because you sweat, you know. And so I think I do think it's useful. How long and how beneficial in the long term it is hard to predict. I don't think necessarily for once they've had surgery, I don't think there's much real benefit, because if they're not being held by whatever there's been put in during surgery, then
depends how tight you tape.
That's a problem, right? So that's the other that's one other thing I didn't mention. The one thing with the screw is you can surgeons in about 30 to 40% of cases can mal-reduce the syndesmosis with the screw. So that means they put the fibula in, put the screw in, looks great on an X-ray, fantastic on an X-ray. But if you got a CAT scan and looked at where the fibula is next to the tibia, it might be being held too far at the front, too far at the back, or too far away, basically. And that has long-term implications. So typically when I've been putting in screws, I actually look at the syndesmosis and putting it in to make sure it's in the right spot. But that's been the typical problem with screws. The tight rope's actually been shown in a lot of cases that they'll sort of slip the fibula into where it should go as you're putting it in. Not certainly if you drilled wildly off the track where you should be, it wouldn't. But that's one advantage. That's the other thing. So patient, the only caveat I'd have to say, so you've got someone that's had a screw for a long period of time, but still very much having syndesmosis pain, that is one thing to potentially think of, although it'd be a very brave person to then run off to the surgeon and say, hey, you put this in the wrong spot. But
Yeah.
but that's something to consider in a patient that, you know, x-rays look perfect, it screw looks good, but
Okay, go from there. All right. Well, any parting words before we jump on to the listener questions? Kelly, did you have any other questions?
I mean, I was interested in going into the different like trimalleolar fractures and the different types of sort of syndesmosis injuries, if we've got time to go through a couple of the common ones.
I do. I was aiming for a 2-part podcast, so like the longer you can make this go, the better.
Yeah. All right. Well, you guys chat because I learned so much. I'm not going to have much input.
The one starting with M that I am too bogan to pronounce.
Maisonneuve. Yeah. The French one. Just so the French one. Yeah.
The French one.
So what are you guys actually talking about? Tell me.
What are we talking about?
Yeah.
Take it away.
Yeah.
Okay. Well, I guess, look, when we're talking about ankle fractures, I guess I'll try and make it really simple. Like when people talk about unimalleolar, bimalleolar, trimalleolar fractures, all we're talking about is how many bones in the or how many breaks there are in the ankle, right? So, you know, uni is 1, bi is 2, tri is 3. Okay. Typically, what I would say in general is that you can have a syndesmosis injury with any of them, but they're more likely, say, if you've got broken more than one area of the ankle. Okay, it's going to be a bit confusing. So basically, like we're talking about the fibular fractures. People would be somewhat familiar with the Weber classification as to what level you break it at. Being the A is below the basic level of the joint or level of syndesmosis, B is at the level of the syndesmosis or at the level of the joint, and C is above that. So a Weber C in a fibular fracture is almost always associated with a syndesmosis injury, and that is actually why it gets operated on majority of the time. The only time you get a high fibular fracture where it's not got a syndesmosis injury is if it's a direct blow. So if someone whacks you with like a tire iron or something like that into the leg, that's not a syndesmosis injury, that's just a fibular break. It'll be fine. It'll heal with time. Okay. But if you've got any rotational injury with a fibular fracture above the level of the joints, that will by rights have a syndesmosis injury with it and should not be treated non-operatively. It should be treated operatively unless the patient, you know, can't have anesthetic or has great risk for some other reason. Okay. When you go further down, which is the Weber B, which is at the level of the syndesmosis, a percentage of those injuries will have a syndesmosis injury with them. Now, a marker of that on an X-ray would be what we call talar shift, which essentially means the talus moves with the fibula laterally. And as a result, there's an increased gap between the talus and the tibia on the medial side of the ankle. Okay, it's called, you know, the medial clear space, basically. It's the medial gutter of the ankle that opens up. So you need a weight-bearing X-ray really to tell that. But that's, you'll see it in some with the Weber B. That'll be what you see on X-ray. You see the fracture, but there's a gap on the medial side as well. That would need to be treated with an operation. Okay. In saying that, a percentage of those Weber Bs that look fine on X-rays and the fracture looks not that displaced may still have a syndesmosis injury. And really, in terms of working out whether it has to be investigated further or whether it needs surgery, it's probably best looked at by an orthopaedic surgeon. There is a bit of conjecture around that as well. Typically, what I do is I'll actually CT scan them because sometimes it's not obvious, but there's a little posterior malleolar fracture at the same time. And that means there's been a real rotational injury and usually means a syndesmosis is involved, and I'm much more likely to fix the ones that got that extra bit. But just as a general rule, if there's a Weber B, so a fracture at the level of the syndesmosis, probably best to refer on to someone else with that.
That's good advice.
Really good. Okay. And then a Weber A, so below a joint, no, it's not going to have a syndesmosis injury. So you do not need to worry about that in that regard. And those patients don't usually need surgery. Okay. So that's actually unimalleolar fractures in a small nutshell associated with syndesmosis injuries. Basically, if you've got any more injuries, so bimalleolar, so typically that's a fibular fracture with a fracture of the medial malleolus, so the tibia on the medial side, big toe side, that's probably going to have a syndesmosis injury. And if you've got a trimalleolar fracture, meaning that usually you've got a break of the fibula, what's called the medial malleolus, so on the big toe side, and a break at the back of the tibia called the posterior malleolus, they're probably typically going to have a syndesmosis injury as well. Okay, but typically as surgeons, we're more often than not treating those fractures, treating the patients that break both with an operation most of the time, and we will usually screen that patient's or look at that patient's syndesmosis injury when we're in there. We actually can go and check it out on an X-ray properly, or look at it ourselves. And funnily enough, the X-rays we get screening it now are probably not that accurate either, so I always go look at it. Okay, like I literally just get an instrument, I poke it between the fibula and the tibia and pivot, and if it moves, that's bad. If it doesn't move much,
just have it written on the whiteboard.
Okay.
Move equals bad, not move equals good.
Yeah. Right. Okay. But basically, just got to think. Look. Okay. If more than one area is broken, there might be. So probably need to refer on. Or if there's a Weber B or Weber C to the fibula, yeah, it probably needs to be referred, because probably has a, well, C's definitely and B's maybe have a syndesmosis injury. Okay, so unless you've got a Weber A, basically that one's the one that's not going to have one, but everything else you'll be at least worried about. Okay, and probably either needs a higher opinion or higher level imaging. Okay, and then the nasal nerves.
I was just going to say, they more often than not will present to hospital anyway, so they're not often coming into the clinic. Really.
True. And so the tricky one is the isolated posterior malleolar fracture. So we have occasional patient that just has a break at the back of the tibia, and people focus on the break, whether the break's going to heal, and the break's going to heal without, unless it's really big. Typically it's going to heal, and I think when patients come to see me, I think they're really worried about whether the break's going to heal, and think that I'm worried about whether the break's going to heal. I'm actually really worried about the syndesmosis, because I find it hard, unless it's a real just a direct mechanism to the back, I find it hard to get that injury without some level of rotation. And more often than not with those ones, I'll have MRI them to look at the ligaments, because the reason is that the posterior malleolus will likely be attached to that PITFL. So if that's broken but the ligament's intact, it's almost like the ligament floating free. It's attached to a broken piece of bone. Okay, and so then if the AITFL, so the one at the front's gone, usually by rights the one in the middle has gone as well, and then technically that's a 3 ligament injury.
Yeah.
Now, if everything stays exactly where it should stay, as in it doesn't move, then the patient might be all right. As in, you keep it pretty still, and the fracture at the back heals, which means ultimately that PITFL at the back is going to be okay. The AITFL scar up in time, they might be all right, but you're taking a risk that fibula can move in the meantime. And then the other thing is that there's another ligament, there's the middle one. And I've just spent, a bit of time saying to you guys, well, if I go to the front and the middle, it probably remains unstable in some cases. Okay. So I've got a bent on operating on those, but I've actually had a few that have seen other surgeons that have not been operated on. But that's just something, that's probably one other injury that if it's isolated to the back there, that probably needs another opinion to make that decision, basically, right? Because then the surgeons then taking, if they want to treat, the surgeon was treating non-operative, that's okay. I don't think anyone can really criticise them for that. And they're taking that risk on. And as long as they've explained that to the patient, that's okay, that's fine. So, when I'm talking to I tell them what I'm worried about, reason why I think it's necessary, but I will say that with people that will treat this non-operatively, and if they choose to go down that non-operative path, that's absolutely fine, as long as they're aware of there might be a little bit of risk with that, basically, so.
Yeah. Does that, do these injuries, does it just mean it's more force? Like when do you typically see these injuries in regards to how they occurred? Like, is it always with contact sport, the more severe ones and more serious ones?
Probably majority, maybe about 7 out of 10, but most of the guys, they're typically men, funnily enough. I guess rugby league are dominating. I don't see them much in netball. Strangely, I think you just do your ACL in netball. I think that's usually what you do. But actually, this is most supposed to be ACL on the ankle, apparently. That's the latest. I know it's pretty cool.
That's a good title for the podcast.
Probably a lot
Yeah,
quicker,
yeah, it's better than saying-
recovery-wise.
Yeah.
It's sort of like saying, well, yeah, because high ankle sprain's a bit boring. Like we're just talking about
Yeah.
sprains.
And it
but,
pricks
you know,
your ears
the
up because there's
ACL.
so much about
Exactly.
ACLs.
That's how going to be our podcast
Yeah.
title, I reckon.
I just said that.
Oh,
Literally just
I was
20
thinking.
seconds ago. You want to listen to him, that's why. I got nothing to do with
I
that.
zone out when you speak.
Sorry, mate. What were you asking me? So, well, typically high energy. Yeah, typically they're.
Mm.
I find they're typically not in sport. I've had one lady who tripped putting the washing out and stuff, and so that happen in other scenarios. But typically, and like for instance, you know, where we're at now, coming into summer, the syndesmosis just seem to go away. They go into hibernation over sort of Christmas, and then here in Australia anyway, and then they come back out. I think I was whinging to Justin actually. I think I was talking to Justin earlier in the year. I was like, oh, mate, I'm really sorry. I've got all this general foot and ankle work, which I've given you a lot of referrals on for, you know, orthopaedics, which I'm sure he was complaining about, right? And I was like, mate, I'm sorry. Like, my sports injuries are dried up. Like where they are, it's like April, March. They should be starting to come back again now. Like, where are they? And lo and behold, in May, they just hit with a bang. So I think they're very much associated with sport, and so I think they'll disappear for a while now.
Yeah.
And come back in.
Yeah,
come back
summer's the
after
time
Christmas kind of thing.
for plantar heel pain and plantar fasciitis. That's your favourite to see, isn't it?
Oh, mate, I love it.
Or
Yeah, you know,
bunions.
like.
What was the question about bunions?
I hear about the French one.
Oh, yeah.
Oh, yeah. Sorry. Yeah. So Maisonneuve, I don't know who Maisonneuve is. If I wanted to sound really smart, I would have looked it up beforehand, but you guys might think I went up. But I'm sure it was French. But basically, it's sort of like a much higher web of the sea. So it's usually mid shaft or proximal shaft of the fibula, and it's one of those ones that really tricks everybody because patient will be sore up high. That's where they're tender. They actually do have some tenderness in the ankle, but no one looks at it. And the imaging is all about the fibula break. And then you think, well, okay, so they've just got a fibula break off. You go and walk on it. The patient is still sore 6-8 weeks down the track. So basically, that injury is a rotational force to the ankle that's transmitted through the syndesmosis up through the interosseous membrane and exits out the fibula. Okay, right. So you get a fibula break. The fibula break is not a problem. It will heal. The problem is this big syndesmosis injury that's occurred further down the ankle and through the interosseous membrane. And so those need to be treated operatively with some sort of stabilization to the syndesmosis, or they're very unlikely to get better. And so you may actually see, so I've had a couple of referrals where that's just been purely a posterior malleolar fracture as presented. And funnily enough, they had the high fibular fracture with it. So they really did have a big rotational force. And I've had other people that have just had an ankle x-ray, weight bearing, where the clear space on that medial side has been really wide. And the emergency guys have run me really perplexed. They're like, but there's no fracture. There's no fibular fracture. Why is the talus moved and stuff? I was like, oh, if you felt further up, like near the knee somewhere, like a bit further down from the knee, and they come back and be like, oh yeah, it's really sore. And you do an x-ray further up and they're like, yeah, there's a fracture there. Like, yep, there's something called Maisonneuve injury. So it's not that well known. All orthopedic surgeons know about it. And so any orthopedic surgeon should be able to pick that up. But that's just one thing to be aware of. If the patient's got sort of mid-shaft fibular pain or pain up in the knee, just check the ankle to see if it's sore, basically. That's all you need to do. Because if they're sore, then you need to worry about that injury. That's all.
Yeah, cool.
Yeah. Did you have any more questions?
No, I'm okay now.
That was good.
Yeah.
That was awesome. Yeah, that was really good. Now I've got a couple of listener questions. So
should we do them rapid fire again, like we did last time?
Well,
rapid fire.
I don't think the first one probably not. And I mean, I'm really, I said this from the start, I'm always excited for these episodes, but I'm really excited to clip your answer to this question because it's a bit of it's always a hot topic in podiatry, but there has definitely been a bit of a movement lately. And I guess there's always the movement of the barefoot minimalist, wearing wide fitting shoes with low drop, prevent all foot pain, and, anyone with any toe deformity or bunion deformity or ankle fusion, everyone just needs minimalist shoes. So one thing that's been thrown around lately, and this was the listener question, was, are bunions reversible non-operatively? And we're talking probably the moderate to severe ones in the sense of strengthening up the muscles on the inside, because I'm under the impression the physiology of the tissue would change within the joint capsule. So yeah, what have you got to say about that?
Well, actually, before you clip it, I'd be interested to see what you think of that, Blake. You reckon they're reversible?
No, God, no. It's thinking you can strengthen the abductor halluc, be able to pull that big toe around. Like, I'm under the impression those structures are tightened and they've changed their physiology.
I wish they were reversible. Like, that'd be great. right? Because the surgery's got a percentage of recurrence rate. So it'd be great if we could treat it non-operatively just by strengthening with the other side. But I guess we don't know the exact pathophysiology of like why they, or so I should say pathogenesis of bunions. We don't really know exactly. Like I'm sure you read some stuff where there's populations that don't wear a lot of shoes that don't seem to have bunions, but just saying it's shoe wear that's the cause is not correct either. There's a strong genetic component as well. So we presume what happens is something causes that metatarsal to go into sort of more varus, basically. Okay. And what that changes the line of pull to all those structures that usually run straight, so that EHL, FHL, all of a sudden they're running in a position where it's increasing the deformity. So rather than running straight up and down the toe, if the phalanx is starting to point towards the little toe, then if the EHL and FHL are attached, to the phalanges more distally, they're actually going to increase the deformity every time they pull. Like, does that make sense? Like, if you rather than a straight. So, and then the other thing is, yes, so the lateral structures start to become tight, and the medial structures become loose or weak, or the tissue. So for instance, as surgeons, we're taught that we can't rely. Typically, previously, they just tried to really tighten the tissue on the medial side of the bunion, and that looks good when the patient's asleep. Like, it looks really good. But then, if you just did that 5-6 weeks later, their bunion will be back to where it was before, and I'll say, well, did you do anything? So when we're doing surgery, we're actually very much relying on the bony corrections more so than anything we do with the tissues. So I wish they were reversible without surgery. Like, I really do. Like, I think for the surgery you have to go to get them corrected, it'd be great if we had a good non-operative treatment that reversed it. But there isn't one there. There's not, and I can't see how any of them would work, to be honest. Once the tissue, you're right, tissues they get very contracted on that lateral side. Like, we have to release them with a knife surgically, a scalpel, right? So you can dry needle them, you can pull them, you can do whatever. Unfortunately, it's not even that easy to use with a scalpel. So I wish they were reversible. I really do. Like bunions are not a bad operation, but there are other operations I enjoy doing much more. Like, it's part of my thing. But so I wish I could offer patients for any forefoot surgery that not like some really good reversible non-operative management, but it's more about managing symptoms with non-operative management for bunions. We can't reverse it once it's there, even in a mild deformity. We can't reverse it with non-operative management. I do wish that was the case. That would be great, but we can't.
Yeah,
unfortunately.
And I've read, and I saw you mentioned before, and I have read that there is a pretty big, or we think that there's somewhat of a genetic component to it. So my impression is, and the patients that I see, I definitely don't, in the sense that there's no symptoms, and we usually see them for an opinion in regards to what can I do to prevent it. We had the long conversation to say that, it follows its own timeline and that kind of thing. But, because there is that genetic component, using orthotics in the presence of no symptoms isn't a preventable measure. Would you agree with that?
I would. I would say that applies to a lot of things, unfortunately. I think there's this sort of bad thing that surgeons just don't like I like orthotics, so I refer for a lot of orthotics. But typically you're treating patients with pain. They're trying to offload areas that are painful or inflamed, and as you know, Blake, doesn't always work. And things you think mechanically should make massive differences sometimes don't. I don't really buy into orthotics as a preventative measure. I know that's from a type podiatry point of view, that can be somewhat controversial, but surgeons don't really have a bent against it. No, I know. We don't really have a bent against it. We just want to do things that we think actually work. And if we had good evidence to say, well, that's a preventative measure that's going to make a big difference, then we'll be all for it. But particularly at bunions, you can put it in your 15-year-old daughter, but you'd be wasting your money, if I'm being honest. So that would be my opinion on it. I wouldn't recommend that to my family. I truly believe that. But if it made a difference, I would. If I had good evidence, I would. But I don't think so. It's a biomechanical problem, but it's not one that you can prevent with an orthotic. I would think, no, I don't have any evidence for that at all. You can just stick a toe spacer in them for 30 years and see how that makes a difference. But I don't. Yeah, but I don't. No, I don't. I think you can't unfortunately beat the genetics in those people, and the biomechanics of that problem will overcome any orthotic probably you've got that a patient can comfortably wear.
Yeah. So, and then our next question, which again, very, very hard to answer, but how soon do you think that kind of neuritis bursa complex in the forefoot should be injected? And this is obviously another podiatrist question, which it's hard to answer, I know.
No, it's hard to answer. I mean, I listened to your podcast on the London foot and ankle surgeon. I always forget his name. I forgot the last one, but and I remember him saying that. Like for instance, he's not super keen on injections and things like Morton's neuroma. He doesn't typically inject. I think it depends on what you're looking for. Like, so he did make a comment. He's like, well, if you've got a burst that's inflamed or Morton's neuroma, if there's something that's fueling that or causing that, that's not a problem on its own. And I tend to agree with that state, particularly maybe not so much in Morton's neuroma, but for things like bursitis, I think that's a sign of an underlying problem, either mechanical or something else, that's driving the bursa to be inflamed more so than the bursa just going off on its own. Like when you're talking to Nikki, it's not like with heel pain, Achilles tendonitis, or with hamstrings. It's usually in conjunction with some other problem. So, like for instance, so I think normally I can't think of the last time I arranged for an got an injection to a bursa. I've definitely done plenty of Morton's neuromas, but not the bursa itself.
Yeah.
No, I know that's not. That's much more common. Like lots of people order it for bursas. I much prefer to rely on mechanical offloading first than looking at injections. And the problem with injecting around the bursa is you're worried about causing other issues like issues with the plantar plate, you cause skin issues with steroid, that sort of stuff. It's not. I don't typically. So I guess Morton's neuroma is a little bit different. I'll speak that in a sec. For a bursa, I'd much rather look at mechanics of the foot. Is there something I can offload? I need like a pre-bent dome. Where's the pain? Is it a plantar plate tear? Do they need more imaging or something like that? Is there clinical deformity somewhere? That's what I prefer to treat. I try and do that with addition of an anti-inflammatory, provided there's no contraindications. And I typically leave my injections as a mix of treatment and diagnosis. And what I mean by that is I always want to know from the patient what benefit they got in the first few hours from a local anesthetic, because that helps me to work out if the area that's injected is the pain generating area. And so the bursa will be sore, but on its own, it's unlikely to be the primary reason for their pain, if you know what I mean. So I much prefer to say be injecting a joint or something else around there that or an interspace where I'm worried about a Morton's neuroma or something like that. Yeah. If it matches up clinically. So when is a hard question, because it depends on the pathology, but I would hold off as long as possible. I would have tried everything else, basically, is the answer. I would have tried anti-inflammatories, or would have got imaging such as an X-ray minimum, possibly an MRI, if I'm worried about, say, plantar plate tear something. But definitely I would have tried offloading with a podiatrist before going down that path. And I possibly would have got if a podiatrist, maybe if you're thinking about injecting, I'd probably get another opinion from GPs, well, sports doc, orthopaedic surgeon, something like that. And then Morton's is a slightly different beast. I do think Morton's neuroma, yes, they've probably been there for a while and all of a sudden become inflamed, but I don't know what you found, Blake, offloading it can be variable. I know the advice to wider shoes definitely helps, but not everybody. So typically with the injection for them, I'm actually really asking for it from a diagnostic point of view. I basically say to the patient, look, we're going to inject next to the Morton's neuroma. You might get some benefit from the steroid. Maybe. Basically, the way I see it is flip of the coin. If you get some improvement from the steroid, fantastic, that's a bonus. But what I want to know, number one, is that definitely causing your pain? Two, if I take it out, is that going to fix the problem? And so if they inject local anesthetic next to the nerve and the patient feels heaps better for that small window of time with the local anesthetic, that tells me usually that if I go take out that nerve, probably they're going to feel better. And if they come back to me and say, oh, I'm feeling really good now, it's been 3 weeks, steroids still working. I say, well, that's fine. Why don't we just let it go for the moment and see how things run? And if you get 3 or 6 months down the track, you might be able to inject it again. But if it only lasts a week or two, then probably we're looking at needing to do something to operate to your foot. So I think once given the more around though, I'd probably try offloading it and wide shoe wear first. And then if that's doing nothing, then probably an injection for that is reasonable. But like I said, I do it for slightly different reasons. I do it less for treatment, more for diagnosis, with the bonus if the treatment works, basically. Yeah.
That's a good answer.
Yeah, good. Mate, if you start recommending wide shoes and Met Dome, I'll have to retire. That's bloody 4 years of my uni course.
Yeah, right. Yeah, right. So,
No,
I don't know. Like I don't. Patients sit there and they're like, I have one patient. A lot of patients just want it out. Funnily enough, I was like, so you want to try something else? Like we try this and that. Like, oh, does it really work? I was like, well, in some cases, they're like, no, just take it out.
Take it out.
And I had one. So then I started like broaching the subject of surgery more quickly with some patients. I had one lady just like, what? You want to take it out? Like, I only just met you. And I was like, yeah, and I was like, that's okay. I don't know. There's definitely like there's other things we talked about we can try, but I've had a lot of patients recently that just think if it's only maybe going to work, they don't want to do it. It's just like, I don't know, I definitely don't want surgery. Like, I was like, yeah, that's fine.
Yeah,
so,
good.
I said, you sort of speak, which is good. No, it was the wrong conversation from my point of view, right? So like I just sort of been lulled into this sense of I had a few 4 or 5 patients in a row that really didn't want to listen about the non-operative, which is what usually I'll talk about, but they just didn't really want to hear it. And so I changed tack wrongly, probably in that regard. It was a good wake up call to switch back. So yeah, but nice.
Awesome, mate. Well, thank you so much for coming on. I hope you enjoy the rest of your day. You're operating today and then you've got 2 days off. Is that right? So you have a bit of time off?
A couple of days off. Technically I'm on call, but we'll just see what grand final weekend actually, funnily enough, is usually less. Well, Sunday night should be less busy.
If the Eels win, it should be busy. But if Penrith win, if the Eels win, I don't think it will be as busy. But if they lose, I don't know. I don't know about the Parramatta.
Don't know. I think the Eels fans are used to losing though. So
yeah, it's just normal for them. Normal weekend.
Just normal for them. You should be able to take it pretty well. They're a lot of disappointment for a long time. So if they lose, they'll be all right. They'll just think back if they're wherever they came from.
Yeah, hopefully in a year we'll be having no, Knight supporter through and through. I was saying hopefully in a year we're having the same conversation and we're talking about the Knights playing in the grand final, but we'll see.
Yeah, mate. Well, mate, they're in the final, right? The girls I've met some of the girls. They are absolutely fantastic people.
Yeah, they're great.
Like, honestly, I cannot speak more highly of the ones I've met. Like, I honestly hope they win because they're a fantastic group of people and a great team. So I really hope they win.
Yeah. Awesome, mate. Thank you so much for coming on. Cool. Enjoy the rest of your weekend.
Thanks, guys. Have a great weekend. See ya.